Hi everyone, my name is Mirvat Alasnag. I'm an interventional cardiologist and I'm here today with one of the late-breaking clinical trials at EuroPCR with Dr. Arun. How are you?
I'm very well, thank you.
Well, today we heard the results of the stepwise provisional versus culotte, and the 5-year results came out. Can you very quickly summarize these results for us?
Yes, this trial was specifically looking at patients with non-left main bifurcation disease. They all had to have true disease, so disease in both the main vessel and side branches, and they were randomized to either a provisional approach or to routine culotte up front. And this was the 5-year results of that trial. And we found that there was no difference in overall MACE rates at 5 years between the two branches of that trial.
So the results were sustained out to 5 years. The initial trial was published that showed us the 1-year results. Is this an expected outcome, or did you think that there would be divergence?
We didn't necessarily think there would be divergence, but obviously there is a belief in the interventional community that maybe 2 stents is required for patients that have disease in both limbs of a bifurcation. What we really have showed with this is that in the provisional group, where there was only 16% of patients that needed a second stent, their outcomes were just as good. And this was both clinical events as well as relief from angina. So it does mean that a large majority of 2 stents, when put in as a routine technique, may actually be unnecessary. We may be doing more for the patient than is needed.
I also understand that you looked at patients who had a side branch lesion that was less than 5 millimeters, in other words, less than 10 millimeters, and those that were
Yes.
10 millimeters and above. And again, the results remained consistent.
Yes, that's right, because side branch lesion length has often been thought to be something that may favor a 2-stent strategy. And roughly half our patients were under 10 millimeters, half were over 10 millimeters. And there was no difference in the two groups in terms of the primary outcome. So once again, reassuring that you can use a stepwise approach as opposed to having to dictate 2 stents up front.
So we didn't know the use of intracoronary imaging in this study. Do you think, had there been more intracoronary imaging, less intracoronary imaging, that would have made a difference?
Yes, I mean the procedures were done between 2011 to 2014, and unfortunately we didn't record the use of intracoronary imaging, so we can't comment on what the rates were. I think along with intracoronary imaging there are several procedural optimization and medication optimization that's happened since then, and it is possible that the event rates would be even lower if this trial was repeated with current era techniques. Yes.
Yeah, so I just want to touch on something you mentioned, which is that the procedure itself evolves. The culotte as we do it today is not the same as it was 5 years ago, where now we're introducing a double kissing culotte.
Yes.
Again, do you think that may change outcomes if we redesign this kind of a trial?
Yes, potentially. Exactly, there have been optimizations reducing the length of stent overlap and the double kiss. One thing that we would point out is that the bifurcation specific event rates were very low at 5 years. So they were about 6.5%, and this was after 5 years of follow-up in 200 patients. So in order to look at differences between the two groups, it might be that very large patient numbers are needed and things that might be a bit impractical, to be honest. A lot of the MACE events weren't actually bifurcation related. They were from de novo lesions, and it highlights the importance of secondary risk factor prevention to try to reduce future events. I think we always need to pursue optimizing stent techniques as much as possible. When it comes down to very small differences in stent techniques that need a very large population to be evident, operators need to use what they're comfortable with, and certainly a stepwise provisional is something that I think every operator should be comfortable with and helps minimize extra procedural aspects that may not be necessary in all patients.
So do you think the antiplatelet that was used primarily was clopidogrel?
Yes.
Do you really think although there was no statistical difference, do you think there would have been lower event rates, lower stent thrombosis, etc., in the 2-stent strategy had we changed the antiplatelet?
Yes, it's possible. A third of the patients roughly were ACS patients, and certainly by today's guidelines they would not have received clopidogrel. They would have been a newer P2Y12 inhibitor, and I think that certainly could have reduced event rates. Certainly, more widespread use of high-dose statins would probably help as well, and new PCSK inhibitors and so forth. So I think for certainly a subset of patients, yes, these changes may have made a difference.
And you did touch on the small number. We had approximately 200 patients enrolled in this study. Perhaps the open label design, do you think that could have impacted the reported outcomes as well? Or?
It could have. I mean, both the patient and the physician were not blinded to the intervention they were performing. The events were adjudicated independently by a CEC, so we, I guess, had to make the best of what a practical trial design could be. But I guess those biases should be kept in mind.
Well, thank you, and this was a very quick synopsis and overview with the primary author and presenter of the EBC TWO trial.
Thank you.